for the lovely introduction. Good morning, everybody. Thank you so much, Dr. Gelman, and the wonderful team of Net Research Foundation. This is my first opportunity to be able to talk at NetRF event. I would be talking about how to treat functional and non-functional neuroendocrine tumors. And I'm glad that I'm following Dr. Chen's beautiful presentation, so she kind of like really set the stage up and gave us a beautiful primer about neuroendocrine tumors. These are some of my disclosures. As Dr. Chen mentioned, there are various ways to classify neuroendocrine tumors based on the site of origin, based on the grade and aggressiveness of the tumor. But I would be focusing on based on the capacity of neuroendocrine tumor to secrete certain vasoactive amines, or otherwise known as hormones. So broadly, the neuroendocrine tumors can be classified into functional and non-functional neuroendocrine tumors. If they are secreting these hormones, they're called functional neuroendocrine tumors, and this is a minority subset. Based on what study we cite, up to 20 to 40% of all neuroendocrine tumors could be classified as functional, and the remaining majority are usually non-functional neuroendocrine tumors. Regardless, both these categories of tumors can cause symptoms. Functional neuroendocrine tumors produce symptoms based on the specific hormone they are secreting. And the common hormone is serotonin. We all heard about Carcinoid syndrome. So serotonin overproduction can lead to flushing, wheezing, diarrhea. We would be talking in a little bit more detail about those. But there are other rare hormones sometimes produced by these neuroendocrine tumors, like gastrin. An excess of gastrin can cause ulcers, gastritis. VIP gives you terrible, terrible diarrhea. It's usually produced by pancreatic neuroendocrine tumor. ACTH, adrenocorticotrophic hormone, this gives you Cushing syndrome. So patient can have subcutaneous deposition of fat and high blood pressure, pigmentation of skin, etc. And very rarely, these tumors can also secrete insulin. Now, our bodies naturally secrete insulin when we eat food, but if it secretes too much of it, you can imagine that our sugars can dip down critically low. However, the non-functional neuroendocrine tumors, which are the bulk of or majority of our patients, do not produce these hormones. However, they still suffer from symptoms. And these symptoms happens to be because of the tumor bulk or the mass effect. So based on where the tumor is, these symptoms can range from abdominal pain, from these tumors being in liver, to bowel obstruction if these tumors are in small bowel. Cancer in general is a catabolic state. So our patients can present with weight loss, loss of muscle mass, fatigue. So these are some of the symptoms which we can see in non-functional neuroendocrine tumors. Most of my talk would be focusing on functional neuroendocrine tumor, especially the serotonin, because this forms the majority or the bulk of the disease burden from hormone-secreting neuroendocrine tumor. Let's dive into some history of serotonin. Dr. Erspermer discovered this compound in 1935. So we've known about serotonin for quite some time. He didn't name it serotonin. He called it entramine. Later, Dr. Rappaport and colleagues discovered another compound with similar properties and named it serotonin. But it wasn't until 10 years later that people figured 1 and 1, and this was the same one and same compound. Since then, we have learned quite a bit about serotonin. Serotonin is manufactured from amino acid tryptophan, which we get it from our diets. It is converted, this amino acid tryptophan is converted into serotonin in 2 steps by various hormones in our body. Most of the serotonin normally is produced in our GI tract, but it can also be manufactured in blood cells, platelets, and central nervous system, brain. Serotonin is very important in our body. You've heard about medication, SSRIs, which boost up our serotonin because serotonin is needed for a normal, healthy mood. Serotonin is a compound which helps our body communicate. The two neurons communicate through serotonin. It's a neurotransmitter in the brain. In the gut, it helps communicate between the nerves and the gut and regulates the gut movement. So it's a very important hormone if produced in the right amount at the right place. And normal serotonin it's stored in the cells and is released when it's needed. And as mentioned before, some of the serotonin is also made in brain and helps in mood regulation. And this serotonin is completely isolated from the serotonin which is produced in the rest of the body because of the covering of the brain called blood-brain barrier. Majority of serotonin, normal serotonin, is produced in gut, about 90% or more. And what's the role of serotonin in gut? In a normal state, gut moves, continues to move every few minutes, 10, 15, 20, 30 minutes. And these movements are called peristalsis. Basically, that's how we eat, and the food moves forward, and we are able to excrete it eventually. And serotonin plays a role in that movement, in the communication, when the gut should contract and move. And the nerves communicate to the muscle of the gut through serotonin. But let's focus on the pathology when things go bad. So neuroendocrine tumors can also produce this hormone, and in very excessive quantities. The tryptophan which we eat in our diet gets converted into serotonin, as I mentioned before, in 2 steps, and eventually turns into serotonin, which is also called 5-hydroxytryptamine, 5-HT. It gets stored in our neuroendocrine tumor cells in these vesicles called granules, and then something triggers it, and it releases these granules in the blood, and patients have the syndromic symptoms. Could be diarrhea, flushing, etc. Eventually in blood, it breaks down into 5-HIAA, which we measure in our clinic in the urine, and that corresponds to how much serotonin our tumors are making. Does it make sense? From beginning to the end product. Neuroendocrine tumors not only make this serotonin, but this serotonin acts as an autocrine loop, which means it stimulates neuroendocrine tumors to make more of serotonin. So it is a vicious cycle, and it encourages neuroendocrine tumor to grow more and more and secrete more and more of this hormone. And we also know from preclinical data and studies, when we add serotonin into neuroendocrine tumor cells in our culture plates in labs, it increases the growth of cells. So we know that it also promotes neuroendocrine tumor growth. So what are the effects of this increased serotonin in the body? Primarily, it causes 2 important things. One, it gives you these functional syndrome symptoms. Secondly, it causes tumor growth. So we will tackle one by one. Let's talk about carcinoid syndrome. What constitutes carcinoid syndrome? It's a conglomerate of various symptoms, but most commonly it's flushing, diarrhea, carcinoid heart disease, wheezing, but as you can see, there are all sort of fatigue, pellagra. Pellagra is a condition of vitamin niacin deficiency where you can have some dermatitis and changes in your tongue and skin. Cyanosis, a bluish discoloration of skin, especially the lips. Edema, swelling of the legs. Telangiectasias, this is dilation of small blood vessels in the skin. Cramps. Some of you all might be familiar with some of these symptoms. So carcinoid syndrome is not just diarrhea and flushing. It's actually quite broad. One of the most bothersome symptoms of carcinoid syndrome is diarrhea. And these diarrhea could be so bad that it can prompt the patient to leave their job and be completely homebound. I've seen patients with 20 or more than 20 stools per day. I've seen patients who needed to be admitted for diarrhea and been on IV fluids. So diarrhea could be a significant quality of life impacting symptom in carcinoid syndrome patients. Besides diarrhea, excessive serotonin, as I said, can also result in fatigue, marked fatigue. And it impacts their capability to do day-to-day activities. Elevated production of serotonin by metastatic neuroendocrine tumor is the driver of symptoms of carcinoid syndrome. Most often, elevated level of serotonin happens when the tumor is metastasized, especially to the liver, because when it goes to the liver and these tumors are making all these hormone, it doesn't get metabolized because the liver loses some of its capacity to metabolize it, and it gets exposed in the systemic circulation. And then our patient usually experience some of these systemic symptoms. What's the role of serotonin in diarrhea? Why do we get diarrhea? So as I mentioned earlier, serotonin helps in gut movement, but excess of serotonin, you'll have a lot more of this peristalsis. So patients very commonly experience bloating, cramping. Not only that, it causes what's called secretory diarrhea. So our gut membrane is lined by all these pores, these different receptors which produces and secretes various intestinal juices which are actually needed to digest our food. But serotonin stimulates it and causes excessive secretion some of those juices. And this is not dependent on whether you eat food or not. So patient can have diarrhea despite not eating and drinking, and has a significant risk of having dehydration from carcinoid syndrome. As I mentioned before, has significant impact on quality of life. So it is really critical to lower serotonin. And the way we do it, I'll be touching up on it briefly, but is broadly either with the help of somatostatin analogs, and we have a newer drug called telitrestat, and of course to treat the underlying issue, which is the tumor. These tumors are making these hormones, so we have various techniques now, including surgery, embolization, systemic treatments, targeted therapy, PRRT, to take care of the underlying issue. Besides diarrhea, there are a couple of other important things that I would like to highlight, which could be quite significant and really important to diagnose early, manage early, and ideally prevent from happening. One of those is called carcinoid heart disease. What is carcinoid heart disease? Excessive serotonin can actually impact heart in various ways. Most commonly, it damages the heart valve. Basically, causes it to get fibrotic, which is kind of like a scar tissue, becomes very thick and non-functional. And once it becomes non-functional, it starts leaking. It really affects the capability of heart to pump and then eventually fails. This is a quite significant complication and needs to be actually ideally prevented, but at the very least detected early, because once the cardiac failure sets in, it is irreversible. There are some other minor mechanisms by which serotonin affects heart, and that it could lead to rhythm issues, so palpitations and arrhythmias. It can also cause pulmonary artery hypertension, where the blood vessels towards the lung gets thickened and pose some resistance. And then it can also damage the heart muscle and affects its ability to pump. This is important data. I would like your attention on the right side of the slide. And what we are seeing there is, as the blood urine 5-HIAA, which is a marker, surrogate marker of serotonin in the blood, right? As the level of 5-HIAA increases, the 5-year survival of our neuroendocrine tumor patient declines from 83% to 50%. This is a significant drop with increase in serotonin. One of the reasons why that happens is development of carcinoid heart disease. They're at a significant risk of developing carcinoid heart disease. So on the right-hand side, you can see as the 5-HIAA level increases, the incidence rate of carcinoid heart disease increases, and this increase is statistically significant. So this is really important, one, to monitor 5-HIAA and to isolate the patients who are at the higher risk and try to watch them very closely for the development of carcinoid heart disease. The way we monitor these patients by doing echocardiograms, some blood tests relevant to cardiac function, and also making sure that the team, the multidisciplinary neuroendocrine team, has a cardiologist which is in tune to the needs of neuroendocrine tumor patients and is aware about this dreaded complication. How do we treat carcinoid heart disease? If for some reason the carcinoid heart disease or the heart's already impacted and the valve has shown damage and changes, that needs to be repaired. But at the same time, we need to add on strategies to lower the serotonin. So medical oncologist and the cardiologist work hand in hand to co-manage these patients very closely. I would be touching on the medical management aspect of it, how to lower serotonin, in a second. Another dreaded complication, fortunately rare, but does happen with elevated serotonin, is called mesenteric fibrosis. Mesentery is a soft tissue which kind of holds our gut together. Excessive serotonin production, especially in the midgut neuroendocrine tumor, can cause scarring or fibrous transformation of this mesentery. And you can imagine if there's a lot of scarring in the belly area, it can lead to obstructions. And these are not trivial obstructions. I've seen patients with multiple obstructions, needed to go to ERs, had numerous surgeries, and unfortunately, when this happens, there's not a whole lot can be done except for surgical procedures to help relieve this. So the key is to prevent this complication from happening by making sure the serotonin is under control, or employ all our techniques to manage that beforehand. So we talked about the role of serotonin in producing these hormones, carcinoid, diarrhea, heart disease, mesenteric fibrosis. But I also touched on earlier, it affects the tumor growth. And that is also very relevant. We know from our studies, patients who have elevated serotonin, unfortunately, also have more aggressive disease. This graph here shows the high urinary 5-HIAA. The patient with high urinary 5-HIAA, median survival was about 33 months as compared to the ones which were relatively lower. This is a significant difference. So what can we do to lower serotonin? Well, going back to this original graph, we eat amino acid tryptophan. Our body, especially neuroendocrine tumor, converts this tryptophan amino acid into serotonin in a two-step process, and then stores the serotonin in granules, and tumor occasionally intermittently release these in the blood and cause these symptoms and complications. One way to tackle is to block the release of the serotonin into the blood. The way we do this is with the help of somatostatin analogs. These are old drugs, one of the best drugs. I would say they form the backbone of our treatment for neuroendocrine tumor. So somatostatin analog work on somatostatin receptors and prevent the release of these stored serotonin. One of the first studies which looked into somatostatin analog and helping with these symptoms was back in 1986. I think I was 1 year old. But based on this really important New England Journal paper, this class of drug was approved to treat carcinoid syndrome diarrhea, the diarrhea associated with VIPomas, etc. And I think it was very revolutionary because prior to that, we had no real way to treat neuroendocrine tumor patients. Patients who are being treated with chemotherapies which don't really work that well. So this was quite transformational. Later on, we also found out that these agents, this class of drug, not only helps with functional syndrome symptom, but it's also cytostatic. It prevents tumor growth. And there were 2 pivotal trials done, one called PROMID trial, which evaluated sandostatin and looked into its role as an anti-tumor agent. And the more recent trial, Clarinet trial, looked into lanreotide as an anti-tumor agent for neuroendocrine tumor progression-free survival. I'll briefly go about the more recent trial. This was the bigger study of the 2. It randomized patient into lanreotide arm versus the placebo arm. And what they found was the lanreotide arm, the patient has a significant improvement in their progression-free survival. We now have long-term follow-up data, and the lanreotide arm, the PFS is about 38 months as compared to 18 months in placebo arm. That's quite significant. So getting back to what are the ways where we can reduce serotonin in the blood? One is using somatostatin analogs, sandostatin, lanreotide, to prevent the release of serotonin in the blood. The other is to block the hormone, which makes this hormone, block the enzyme which makes this hormone. And this new class of drug is called Zermelo, tellitrostat ethyl. This drug was evaluated in a large phase 3 international trial called Telestar trial. And there were 3 arms in this trial, the placebo group and 2 varying doses of Zermelo group, 250 milligram TID and 500 milligram TID. And what we were able to show in this trial was by blocking this critical rate-limiting enzyme, you can actually reduce the serotonin production. And urinary 5-HIA was a biomarker used to prove that point. This translated it into better control of carcinoid syndrome diarrhea. As you can see, the black is the placebo arm, and blue and the green are the treatment arms, and the stool frequency is lower in the treatment group. Based on these findings, FDA approved this for carcinoid syndrome diarrhea, which was not controlled by somatostatin analogs. So in summary, serotonin overproduction is driver of carcinoid syndrome. Serotonin plays a major role in development of carcinoid heart disease, mesenteric fibrosis, pulmonary arterial hypertension, among various other issues. It also has demonstrated effects on tumor growth, and it's very critical to control serotonin, to not only improve the quality of life, but to also improve the progression-free survival. Very briefly, in last 2 slides, I would like to touch on the other functional syndromes. Very rarely, neuroendocrine tumors, especially pancreas, can secrete a hormone called VIP, vasoactive intestinal peptide, and can give terrible diarrhea. These are also somewhat treated in the same way like carcinoid syndrome with help of somatostatin analogs. Gastrinomas can present with bad GI ulcers, duodenal ulcers, gastric ulcers, and they are treated with PPIs. Sometimes we have to add H2 blockers, Zantac, and pantoprazole. You guys have heard about these agents, and it really works well. ACTH, the Cushing syndrome, we often start them on ketoconazole. It's an antifungal drug, but really works well in blocking this hormone production while we work with our surgeons in debulking the tumors or taking the adrenals out. And then very rarely insulinoma, or pancreatic neuroendocrine tumor subtype, it can produce excessive amount of insulin and cause really critical low blood sugars. I've had patients who needed to be on continuous dextrose or glucose infusion because we weren't able to control their sugars, the tumors, and they are treated with a dioxide. And the way we treat these tumors, the non-functional neuroendocrine tumors, just a quick slide on it, can cause, as I mentioned, bone pain, and they are treated with PRRT if the disease is quite systemic. And if there are just few spots or oligometastatic disease, can consider radiation. Abdominal pain, some of my colleagues will be talking about some other interventions which we can use to control or debulk these tumors to control some of the symptoms. With that, I would like to conclude. Thank you so much for your attention.